Hi team, welcome. This is case 0 of Radiology Beyond Borders. I'm being the example of why it may be possible for you. As you can see, my English is not perfect at all. I'm super out of my comfort zone, but I deeply believe that using this tool, English, to communicate cases, to discuss clinical scenarios, may help us tremendously to open up to a bigger and better community of like-minded people, radiologists, doctors who are interested in radiology. So let's begin. The case today is about an indeterminate interstitial lung pattern. My name is, if you don't know me yet, Cecilia Ferrario. I am from Hospital Universitario Austral in Buenos Aires, Argentina. I'm with my mate here, and this is supposed to be an open space, a safe space for us non-native English speakers to communicate freely and to be able to improve our medical or professional English. Let's begin with this case. It is a 40-year-old male. He has history of chronic kidney disease on hemodialysis and congestive heart failure. His symptoms, dyspnea, chronic shortness of breath, and the CT was done for a follow-up of the chronic diseases that he has. The main imaging findings on this CT where this fine reticulation, you can see bilateral fine reticular pattern caused by septal thickening. It's fine reticulation versus gross reticulation that can help you a lot in trying to distinguish the different reticular patterns that you can find in CT. The distribution is also super helpful when trying to think differential diagnosis. In this case, the reticular pattern is diffuse and homogeneous. You can see that it affects upper lobes, the middle regions of the lung, and the bases of the lung, and it is associated with centrilobular ground glass micronodules. So it has a peribronchial distribution. Also, as you can see, predominantly in the lung bases, we can see a mosaic attenuation, some areas of higher density and other areas of low density or low attenuation in the lung. And here we do not have an expiratory acquisition, but we can think about the probability that this mosaic attenuation is caused by or due to air trapping. As you can see, to describe these images, I'm using helpful phrases or words that are not natural for me because I describe cases in Spanish. So when you are presenting your case, you can use as many words as possible to try to describe the image that you are showing. Just be mindful that images are the key components of your slides. So they should always be bigger and the text should be short. As you know, when analyzing a chest CT, it is very important not only to see the lung parenchyma, but also take a look at the soft tissue windows where we can find ancillary findings that can help us with the diagnosis. For example, in this case, we can see dilation of the left heart chambers with pericardial calcification that can be the manifestation of a sequela of prior pericarditis. In the abdominal region, we can see splenomegaly, reduced liver size that can be in keeping with chronic liver disease, and also bilateral renal atrophy with simple cortical cysts. So after analyzing this pattern, we came out with 3 differential diagnoses. The first one is HP, hypersensitivity pneumonitis, because of its centrilobular distribution. I don't know if you remember the micronodules with ground glass attenuation. The pattern is diffuse. We do not have a basilar gradient. We do not have a predominance in the upper lobes, but we have all the areas of the lung affected, and we also found this mosaic attenuation in lung bases that could be in keeping with air trapping. On the other hand, we thought about NSIP or non-specific interstitial pneumonia because the bilateral, symmetric, and homogeneous distribution with areas of ground glass attenuation, but I don't know if it happens to you when you see a case and you remember that you have seen that before, and that happened to me with this case. So I tried to recall, and I found this post 1 year ago with a patient that also have congestive heart failure, and the characteristics of the septal thickening reminded me of chronic pulmonary edema or pulmonary edema, interstitial pulmonary edema. So I thought to myself and to people following me on X, do you think pulmonary fibrosis secondary to chronic pulmonary edema is a thing? I really want to suggest that diagnosis in this case. I never read about it before, not as a particular interstitial pathology in CT, but I received a very interesting response or message from a colleague in Chile, Dr. Gutierrez, who told me that he frequently sees this in his practice, and he explained to me the pathophysiology. This is created with NanoBanana. I use this tool to create medical infographics. It is not perfect, but it can give you an idea. And what he explains to me is that an episode of pulmonary edema generates increased blood pressure, which produces capillary extravasation, hemosiderin formation that lead to hemosiderin-laden macrophage, and those macrophages start to accumulate inside the interstitium, the intralobular, the interlobular, and the peribronchial interstitium, creating this interstitial thickening that we see as a reticular pattern on CT. This also explains why we have areas of air trapping, because the accumulation of macrophage in the bronchiolar wall or in the peribronchial interstitium generates a reduction in the caliber of the airway, producing air trapping, and therefore all the imaging findings that we saw on the CT of our two patients. So, what helped narrow the differential? The key clue was, this phrase is very hard for me. The key clue was hemosiderin-laden macrophages on bronchoalveolar lavage. This was confirmed by the pneumonologist, and this helped us understand the pathophysiology of the interstitial pattern that we were seeing on the CT of our patients. So the presumptive final diagnosis, we did not have a biopsy of his lung, is interstitial lung pattern secondary to chronic pulmonary edema. Our teaching points in this case were always start with pattern recognition. Careful identification of the imaging pattern is essential. Evaluate its main characteristics, including distribution, because these features are key to building an appropriate differential diagnosis. Second teaching point, look for ancillary findings that help narrow the differential. Associated findings may be crucial for interpretation. In this case, cardiomegaly, splenomegaly, and the history of congestive heart failure were important clues that supported the diagnosis. And the final teaching point, as most of you know, multidisciplinary meeting and correlation is fundamental. Correlation of imaging findings with the clinical history, symptoms, and additional results, such as bronchoalveolar lavage findings, in this case, is essential to reach the final diagnosis and to guide further diagnostic decisions when needed. And with that, this is the end of the case 0 of Radiology Beyond Borders. This was an example of what we are going to do in our monthly virtual and live meeting. I hope you join me in the description of these cases. I leave you a template that you can use to prepare your own case. You can send that case to me, and let's hope we are creating together a big community with like-minded people that are looking forward to keep growing in radiology. Thank you so much for your time, for being here, and I hope to see you very soon.